just filled with respect and admiration. I've always liked you, Justin, but now I know really the full depth of your skills, and I can't thank you enough. But of course, that extends to everybody in the Myhre Syndrome Foundation leadership. Um, I would be remiss to name everybody because I don't want to miss anybody, but I'll just give a couple little anecdotes. At a time like this, we're looking forward, but it's fun to look past. And I remember the first time I met the first parent, and that was, I have to say, Kathy Young. And we talked on the phone. I nudged her. I said, Kathy, we have to create a group. We have to do a meeting. I'm like most of the other physicians, I draw from experience with other support groups. Doesn't mean divided loyalties. It means that it helps enrich what I'm doing right now. I also want to thank just each person, the organizers of the meeting, Inez and Margot, Kate Weirs, Maya Aziz, just fantastic. And also I hate to say patient, the individuals who live with Myhre syndrome, Patty Schultz and others. So thank you. I hope I've caught everybody. So I just want to also add that I did stop into the coffee room a little bit just to listen in. Most physicians do not participate in your Facebook page. I think of that as your space. I feel like I'd be nosy if I jumped in. But I learned a lot just in 5 minutes. I'm listening. And I have already mentally revised some of my talk right now to be more appropriate for this broad international audience. So let's see if I can start the talk now. I'm going to share my screen. Let's see. Exit full screen. Sorry, guys. Okay, so I have my talk. Forgive me, everybody. I'm just pulling it up. Share screen. Okay, this should be it, guys. I hope people can see it. Maybe let me just do a quick poll. If somebody wants to send me a chat, if it's not working.
Dr. Lynn, we're great. You can
All right. Well,
looks
thank you.
awesome.
The voice from above. So everybody, I've titled this talk, Your Child or You Have Myhre Syndrome. Now what? And it's learning about this rare syndrome and creating a personal care team. This is not a deeply scientific talk, folks. It's more of a pep talk. It's more of an overview. It's a time to give you just one approach or just a philosophy about how to live with Myhre syndrome. And I want to disclose, as we usually do in the US, other things that I do. So I work for the board. This is unpaid. I work for the editorial board of the American Journal of Medical Genetics. I also work in public health. I work for the Massachusetts Department of Public Health and Surveillance. I want to thank you once and a million times to the Myhre Syndrome Foundation. So in 30 minutes, I hope to do this so we can have 15 minutes to talk, discuss the importance of creating a medical health care plan. Many of you live and breathe this every day. Many of you haven't quite gotten to that place yet. Share ideas to do this, make it a deliberate process, starting today, hopefully. Create a team, your personalized team. Think of this as a pep talk, not a lecture. We're going to work together to surf this wave and roll with the challenges that Myhre syndrome brings. Throughout the conference, you're going to hear repetition and redundancy. It's a good thing. Talks are complementary. They overlap, they nicely merge. And for example, for this talk, you're going to be hearing Dr. Matt Thompson, a great PCP on our board. He's going to give you his perspective. And so again, the repetition is fine. So you know what? I think I skipped by one slide. Forgive me. Hopefully it'll come up later. I want to say that I know as I look at the audience, and even though I'm looking at a screen, I feel like I'm looking at you. There are people who I call the rookies. They're brand new. This is a new thing to you. And then there are individuals who I would call the pros. Some of you could give this talk for me. You know this. This is your deal. But I also think about the people who aren't here. So they might be people who just didn't have the time. They'll get to it later. There might be people who I hope weren't stopped because of the registration fee. But I think of people who aren't here because they deliberately cannot be here or don't want to be here. Some families have told me they're just not ready to really take the plunge like this. And I do want you to know that I have not forgotten that we have individuals who have passed away. And I do think about people. In fact, it was a person at MGH who had died that really inspired me, 7 years ago. And I just felt we can do better than letting this happen. We're going to work on it. I have some abbreviations not to read through now. This will be handy when you view the talk on your own. Okay. So I can never know exactly what you've experienced, folks. I can try, but I don't know exactly. But people have said to me, it's like a tidal wave. It's like being wiped out. It's like having a door slammed in your face. It's a broken heart. But as I listen, other people will say, this is that missing piece in the puzzle. And I actually heard it this morning in the coffee room. Or it's like we found that needle in the haystack. And for many families with various genetic diseases, it's a voyage, it's a trip. You're going from port to port, hospital to hospital, finding a doctor that'll give you an answer. And when you get the diagnosis, and hopefully somebody who's your care team leader, it's like you're heading for your home port, okay? So as you start out, obviously you hit the online searches, Google, and I do too. And I want you to know there is stuff out there. So I worked very deliberately with the group called Nord, which is a wonderful group, to create their little summary. There's a new one that I've read about called OrphanNet. It was authored by Dr. Garavelli from Italy, and I encourage you to see. It's a very sophisticated, insightful review. And then many years ago, Lois Starr, Lainey Lindor, and I, we created what's called the GeneReviews. It was a start, and we're going to review it, revise it probably next year. And finally, and bestie, I have to mention the Myhre syndrome site itself. So thanks to Kate, who's really building up what I call a knowledge base, all this cool stuff that's accurate and reliable, and I, encourage you to check out. So, Myhre syndrome has a spectrum of features. I don't need to tell you, you would be telling me. Each person has some of the features. Everybody does. Most people have many, and some people probably think, my gosh, I have everything. Everybody is beautiful. You're wonderfully unique. This is a spectrum. You're like snowflakes. You're all different. There might be overlap, but you're different. We don't know yet how to predict who will have what, when, and how. We're working on it. This is no longer a world where it's top down, where doctors talk down to the patients. Nope. You can tell I'm a sports fan. I think of baseball. We're on the field, we're playing catch, we're rolling it around. We get some strikes, we get some hits. So we work together. It sounds corny, but that's how I feel. So I'm going to start by saying I want you to build a team, find a coach. It might be you, but I hope you can convince a doctor to really take the lead. A lot of having a rare syndrome is like going to a meeting and you leave and you become sort of an apostle, a disciple. You got to go out there and convince people. You're a teacher. And people say to me, wait, that's backwards. Shouldn't they be telling me? But in fact, with a rare syndrome, you got to lead it, right? So your home base will be your PCP. In different countries, it's a different doctor, pediatrician, family doctor. Health maintenance is the basis. No matter what I tell you about fancy tests, you still got to get the vaccines. You got to think about growth, your development, your nutrition, all the basic stuffs. We have to keep our kids safe. So child safety is part of it too. And your PCP, again, at least in the US, is the one who makes the referrals to specialists. But you folks can make self referrals, as many patients have done to me. And of course, your PCP cares for common illnesses. As I said, helps to have a coordinator. Some people it's do it yourself. I'm going to show you a clinic model. We're going to support the PCP as the leader, and I'll help watch for the different details. And I'm so aware that some people are shaking their heads, say, yes, I get it. Other people are saying, no, this is not what it's like in my country, in my city, in my state. But one of the things that we do is with my team, with my website, we have lots of handouts. There's a basic one for the PCP that was made with Matt Thompson. We've started our translations, and thanks to Kate Weirs for starting the same thing on the Myhre syndrome site. So here's a model. It begins with the primary care physician at the center, always the core. If you have the luxury, you're going to build a team. So, for me, I think of geneticists as leading the teams in the United States and certainly at Mass General. And I have sort of this core of 4 or 5. Cardiology, Mark Lindsay, you'll hear him. Pulmonology, Bernie Kinane, you'll hear him. Physical therapy, orthopedics, ENT, Mike Cohen, and what I call brain health, the people responsible for neuropsychology testing, therapies, counseling, medication. And out there, we also have at MGH just about everybody else. These are the different things: dermatology, GI, eyes, joints, neurosurgery, neurology, and urology. And all of these overlap, folks. I just put them in one big bubble, but they all overlap. So I'm like the Gloucester fisherman for New Englanders. I'm trying to be at the helm to help you. I'm not taking over. I'm just trying to help you. Just have to pause. Something's happening to my animation. I don't have the most recent version, but I think we're going to be okay. Um, I wonder if, Amanda, do I have the ability to shut down and reboot, or should I keep going? So, question to Amanda: do I have the ability to just stop sharing screen, pulling up the correct modern one?
Yes, you can do that.
Okay, let me do that. Folks, pause, have a sip of your coffee. I'm going to stop share. Okay, apologies everybody for that delay. Sorry about it. And I did get a message just saying, reminding me that there is a chat, and I know about that. But what I would really prefer to do, to stop in the middle right now, would really change sort of the momentum. It would take too much time, and we're not going to deal with some of these detailed questions. So, folks, remember, this is an overview. This is not the time that we're going to discuss COVID or things like that. Those will come later. So let me continue. So back to this image of our care team. So it shows you how many people we have. We cover all the age groups, we have all the specialties, and we're able to talk together. And we now have a wonderful research assistant, Eleanor Simone. Thank you very much to the Myhre Syndrome Foundation, also to many generous donors to our MGH fund, which is something I also maintain. So in addition to MGH, this is not just the only place. We have this wonderful international board. These are the various countries. And in the United States, there are different places with expertise. We are the only one that has a multi-specialty clinic, but I know from the doctors that you've worked with in the US and abroad that there is great expertise. So there are some cardiogenetic clinics. There is the United States, many different genetic colleagues of mine that I know well. Canada has rich resources. In Europe, you're going to hear some of our colleagues. Again, wonderful expertise. This is really a rich field. I've also tried to explore my colleagues in Australia and in Asia too. So, one of the things I just want to pause and talk about, which is disclosing a diagnosis to a child, to a family, or a friend. We tend to forget about it, but there's lots of flexibility, no wrong or right way. When to do it, you want to avoid prolonged secrecy. I'm a believer that secrets are really hard to keep, no matter how hard you try. When you disclose it, though, depends on the person's abilities, the temperament, and the curiosity. How to do it in a comfortable setting, family centered time and place, who to do it, usually the parents, occasionally the physician assisting, but it should not be the physician only. Despite the best efforts, leaking can occur. I think one of the reasons for doing it is the fear of the unknown. Somebody might think, well, maybe Myhre is an infection. It's like COVID. Did I catch it? Could I give it to somebody else? And certainly siblings worry about some of this. And when you make the disclosure, use words like difference, variation. I never say normal, abnormal. And stress the support. You're the same person. You haven't changed. This could help us all. So, what test do we use and what are the type of tests? The ideal test is called evidence-based guidelines. Every doctor provides care based on their personal experience. I certainly too. But you want to do something that's more rigorous. So, I'm using an example of a group that I work with called Turner syndrome, completely different from Myhre. But we had a great big conference in 2016. We created these guidelines published in 2017. But this is not something we have now. It is a future goal. So what we do in the meantime is we use these gene reviews. Remember, I mentioned that as a resource. It's not perfect, but it is very useful. It's one-stop shopping. It's free. It's for providers. It's for their physicians. It is for the patients and families too. And if you don't know about it, this is something to check out after the conference, gene reviews. So the way I'm going to approach the care is across the lifespan. This is the way most doctors think about it. I want to make it more direct and I explain it to you. I have a couple little cartoons I picked up from the internet. We think about how we change over time, from preschooler to adulthood to the seniors. Here's a little image that's focusing more about growth. I found this cute little cartoon showing a young woman going through her different stages, professional, personal. And it would be kind of, I think I have another slide which says it would be fun to have to create one for Myhre syndrome, something that um, resembles this. So we're going to talk about what to do and when to do it, care across the lifespan. So I think of prenatal, neonatal, toddler, child, preteen, teens, young adult, adults, and seniors. And those of you listening, you could say, well, that belongs to me. So we for some of these for all of these for all of these age groups, we're always going to be thinking about the diagnosis as the core part. Does everybody know what it is? Do we need to explain it? Heart, airway, breathing, ears, growth, behavior, development. They're sort of the core ones. And then with time, we add on additional features. We add on features such as growth, sleep, joints, school when kids become school age, social functionings, autism spectrum, delays, and premature puberty. And then for the most senior individuals, we switch gears. We're thinking now less about heart defects and more about blood pressure, coronaries, arthritis. Cancer, which will be discussed in a separate talk, diabetes, liver, quality of life, career, cessation of menstruation for the females. And again, I'm expecting people to understand what I'm talking about. But what I say today may change over the next few years. We're doing our best now, but this is a work in progress. So to begin, I don't know of any person with Myhre syndrome diagnosed prenatally. It is theoretical. And when that happens, the doctor who will be involved will probably be mainly the geneticist, the genetic counselor, as well as all the obstetric and other providers. How could this happen? A prenatal ultrasound might show a small baby, short limbs, a larger head, short neck, short fingers. And that might be the indication for the doctors to say to the couple, we can do some testing. It wouldn't be standard chromosome analysis. It has to be something much higher, more intense called whole exome sequencing. You'll see these three letters a lot. Okay. And to obtain this information about the baby, you need to do the amniocentesis. You can't do anything non invasive. And it is quite possible that a SMAD4 mutation could be detected We would need to provide tremendous amount of emotional support. Because this is theoretical, I'm not going to dwell on this. We're going to move on. So let's focus on birth and infancy. Increasingly, we're seeing younger patients, which I think is a really good thing. And it's because doctors have a lower index of suspicion, a greater willingness to start testing quickly. So at the top, I'm always going to put down the family doctor. This remains the most important person. And so for kids, we're talking about general health, nutrition, vaccinations, blood pressure, vision, hearing, hips, and development. Just a sample, not everything. Again, this is an overview, folks. It's not a detailed review. The geneticist should counsel about Myhre syndrome test results. This should be ideally a sit down meeting in person. You might hear about it on the phone first, but you really need to have that face to face engagement. The cardiologist plays a huge role. Every person at the time of diagnosis with Myhre syndrome needs to be seen by a pediatric cardiologist. I know there's some countries that don't have pediatric cardiologists, so at least you try to have somebody who's skilled in seeing kids. So there's a baseline consultation, echocardiogram, plan for a CTA, which is a type of CT scan at 6 to 7 years, follow up at least once a year. Many of you are probably saying, boy, I didn't know we had to do so much. And this will be developed by Dr. Lindsay in his talk. A cardiac surgeon might come into play if there's a heart defect that needs to be fixed, a coarctation. About this time, constipation starts to appear. Not everybody, but most, and a real challenge. Sleep can be a problem. We want to check the airway. Home behavior and lifestyle does matter. So sometimes a chaotic home is a little bit more difficult to manage, but it can happen regardless. Hearing, ear infections, the copious ear wax that happens in Myhre syndrome, vision, less farsighted, less nearsighted, more farsighted, and astigmatism. And we really engage all sorts of therapists, physical therapists for the stiff joints, speech therapists for the delayed speech, which is common, and so on and so forth. Okay, so now childhood, so a little bit older. Again, those same basic things that the PCP carries out. And that same advice that if you are diagnosed in childhood, have meet with the geneticist, go over the diagnosis. And again, the cardiologist still plans a role. If this is a new diagnosis, do the baseline, continue the follow-up at least once a year. So I'm introducing a concept I call brain health, which is all those other things. We think about cardiovascular health. I'm going to talk about brain health. I believe very strongly in what is called a neuropsychologic evaluation. It's very sophisticated. It's different than what is done in school. It really gets into the whole person. I've watched several and they're fascinating because they include much more than IQ testing. They include the way a person thinks, draws, speaks. It's the whole person. As needed, some people do need counseling. As needed, some people do need to meet with a psychiatrist. They're very hard to get everywhere, even in the US. And also, peer support can be helpful. There can be therapies, as I've mentioned. And for those who have autism, I can't say enough about ABA. And we'll talk about that later. It's really, really important. It's not a drug, but it's the best that we have. Constipation, again, in childhood. Uh, these are some things I already mentioned, so I'm going to sort of pass over them. So now here's an interesting time, preteen and teenagers. Things are starting to change a little bit, okay? The basic stuff again, family doc, geneticist, neuropsychology, cardiologist, GI. Now we're going to start to talk about puberty, okay? Because there is a type of, we do see some premature puberty in both in both girls and boys. There is some relationship to some other things. It's going to take a lot of talks to really work through this, not just mine. We talk about sleep again, audiology, and now we're starting to think more about the child developing and going through advanced grades. So the goals are less about simple skills that are more academic, and we really have to keep an eye on the children who may be on the spectrum. So, in my experience, I have seen so many children where I can know as a toddler, I can think that there's going to be somebody on the spectrum, but we sort of hold off making that diagnosis. We need to involve the real professionals. And I'm a geneticist, I'm not a psychiatrist, a developmental person. And so when we get to the young adults, depending on your state, your country, you want to at least be thinking about the transition to the pediatrician to the internist, from the pediatrician to the internist. There are some pediatricians in the states that can see these young people till they're 21. It's a great thing. Others have a firm cutoff at 18 and you got to make the switch. And it can be hard. It can be really, really hard. If you have a family doctor, they might be seeing you through the age span. Again, these are very familiar concerns: brain health, cardiology, and now we start to think about an adult cardiologist, somebody who's going to be thinking a little bit more about sort of your coronary arteries, your overall function, your blood pressure. Still thinking about constipation, but now weight, I think, becomes even more of a concern. With so many of the kids, we try so hard to get them to eat, but then as they enter their later years, the weight becomes an issue. People do not have tall stature. They can't stretch out that weight. There is short stature for most, but not all. There is activity. There can be diminished activity in the pandemic, the isolation. So there are lots of reasons why weight happens, high weight happens. And now for some of the women, there are heavy periods. And this can be a signal of a bigger problem. I'll start to engage other people like a gynecologist or an endocrinologist. So we think about nutrition. I don't like to think about weight alone. It's not always the scale. Patients have said to me, "Oh, Dr. Lynn, I just hate it when you ask me what I weigh. It's really can be very painful." We all have to avoid too much TV, surfing, computer time. I have to take my own advice. For many of us, the easiest exercise is walk, walk, walk. Not just walk to the refrigerator, but really walk around the house, up and down the stairs. Find your own gym in your own home. And find the sports, the stuff that you and your child like. Notice I'm saying that you and your child because it can't be just saying to the child or the person with Myhre syndrome, you do this. It always works best if we say, let's do this as a family. For strong bones, remember real foods, okay, not just the ones that come in packages. And again, this idea of a family focus instead of the person with Myhre syndrome. So this is this notion of transitioning care. People in the United States have developed this, and I should say in Europe too, forgive me, but there is something called the American Academy of Pediatrics. This is one of my special patients. This is her at a younger age, a fearless woman, and this is her now as a fearless older woman going through her transition. Folks, I generally will not mention anybody's name, but people know who somebody is, and I hope I'm connecting in this way. And so there is literature out there. There is literature that says, okay, how do I do this? Beyond what Dr. Lynn said, what else can we do? So there are lots of guidelines and the idea of transferring to an adult provider. So again, differs in Europe, and I respect that. So now we're up to seniors, an age group that I'm very partial to. And so we have, again, the same things, but I'm adding some other things like quality of life, activities of daily living. And what this implies is that there are people who have Myhre syndrome who will always need the support of their parents or a spouse. There are some people who live completely, truly on their own. And I've heard about some, I haven't met anybody in particular. Most of the adults that I know that are the highest functioning do have the support of a spouse. And I think that's a team, right? So same things, brain health, adult cardiologist, GI, joints become an issue. Joints are an issue actually when you think about it from being a toddler, these stiff joints. And now we have a concern about arthritis. We're starting to learn more about this, how this differs from standard arthritis that people get. There is a difference. Menopause, maybe there's not only early onset menstruation, but but earlier menopause. So something's going on. We don't quite understand it. We're still thinking about sleep and snoring, still following the hearing because really the majority of people do have hearing loss. And so here's a question. Could one great provider do all of this care? In different places, it's called a PCP, family doctor, GP, pediatrician, primary care doctor. And I would say it's a challenge. I'm glad I don't have that role. It's really hard to do it at every age. And again, we're going to let Matt Thompson talk about that later on. He'll give you his opinion. So I want to talk about something called the equipment check. Okay. We all have our cell phone, but we have to do a little bit more. When you work at many US hospitals, you have to do, excuse me, sorry, we have to do our communication in a secure manner because the internet, as we know, is so open. Many patients and parents will say, look, I'm out there on Facebook, I'm out there on the internet, it doesn't matter, but it does to us. And ideally, especially when you work with us at MGH, we do need to use a secure portal. Sometimes I'll use regular email if I just need to get in touch with you. It's really important that doctors get to review other records. So we have the ability, we use a system called Epic, and it's very cool because it lets me look into other institutions. It's been really hard, to be honest, to work with families from outside the United States. It's hard to get records, and I realize that you live in different healthcare systems, which have their strong points and then their challenges. But you can always go low tech, fax letters, reports, surface mail, that still works. I can sometimes talk to a PCP or specialist. Following over 40 patients, it's impossible for me to talk to every doctor and every patient before I get to know them, but I usually do try. Keep a calendar. If you're not organized, you got to start now. Address book for different people. Use the cell phone camera to take pictures. It's a great photo directory. I know, it became more aware during the pandemic, but that not every person has something besides their phone. I really inappropriately assumed everybody had at least an iPad, some sort of a pad, a laptop, or a computer, but that's not so. But I urge you to try to get access to it, even if it's not your own. And the reason is that certainly when you're working with me, I want to send you stuff. There are things that we might need to send to get you registered. And you need to be able to see more than just a text. As you know, in a text and an email, you're just reading sort of the top part. So virtual visits, if you're able to do them with me, requires a camera on a computer or a handheld. I unfortunately, by the way, can no longer do virtual visits outside of Massachusetts or the states where I have a medical license. So here's a handy tool, a tape measure to measure your child's head, your own head, have a scale at home. And for some people, I encourage getting a blood pressure monitor. We can buy them in the States at some of these drugstores or other, you know, stores. And it's a way to desensitize a child to the device. It can be scary to get your blood pressure done. And for adults, it's a way to do this yourself at home. So I want to encourage everybody to manage your reports, your handouts, your papers. So many different ways. You might have a box, a special drawer, one of those accordion folders. If you're electronic, if you're modern, you can scan them, create something online. I use something called Dropbox. I'm not endorsing it, just what I use, but there's other things, as you know. You could try to ask your providers for copies of their reports. Some can do it, some cannot. Doctors do a lot of stuff on their own, guys. We don't have staff who does do everything for us. So when you work with us at MGH, you can actually go into your electronic chart and see these things. And when you get them, folks, print some of them out and distribute them. Again, be the connector to all of your different doctors. I know it's hard because you expect people to be doing it for you, but you got to do it yourself. Medication management is a big thing. Keep track of what you have, when, show it how it changes over time. Some pharmacies in the United States have this really cool auto renewal service that can make your life easier. Check your bottle label frequency. Just make sure that you're taking what you think you are. And contact your providers directly using secure email. Said that already, okay? I'm watching my time. I encourage some people to try this. Try getting a secure USB and memory stick. Download stuff. Then it's portable. If you show up in somebody's office, have them plug it into their computer. You show up in the ED, say, this is my child's life, and it's right there. Other people are much more cooler than I am in modern. They already saved to the cloud. Good for you. But do try to save the most important tests, such as the one with your genetic diagnosis. And this is handy because we're all people on the move. So, despite all this stuff, I'm tired just thinking about it. We want to take some time out, okay? And I don't have to tell you, but you want to take some time from your schedule, from all this doctor testing for the fun stuff in life. And I'll let the pictures speak to people that I know that have a good time. I think this conference brings with it not just education, but a lot of joy. I'm fascinated by rainbows, and it's funny how you can find a rainbow shining over somebody with Myhre syndrome. I love that picture. And people still get out there and they're doing sports. So not everybody can do everything. I realize that. I also want to recognize something that one of the mothers of my patients called my attention to. She said, Dr. Lynn, it's great to talk about self care and all this other stuff, but for many of us, caring for a patient with extra needs, we never rest, especially if the child has extreme behavior, which does happen in Myhre syndrome. Some children, depending on the age, depending on the education, depending on a lot of variables, are easier. Okay. There's always those things that you need to think about. But some children, some people have more challenges. And this mother put me in touch with um, a statement by a mother who said, it's a special form of exhaustion. We're never fully rested. So, tips from this mother and others: remind parents that they are not failing. I try to just champion them, clap, high five, whatever. Listen, provide some respite, give them a break. To friends and family who might be out there, if you can, an evening, just some time to help your friends or family members. Ask not only how the patient is doing, but how are you doing? How is the parent? I'm sure most of you are doing this. I just wanted to list it. And the frustrations, as you know, the scheduling, the need to be an advocate, the risk of burning out. Because as a parent reminded me, you're constantly telling people about your story. But sometimes that's actually really good. So we've talked about this idea of collecting stuff, collecting a knowledge base, building it, a library. We've gone through these URLs. I love websites because they're free. Come to my clinic. You can see a bunch of stuff there. And of course, visit the Myhre Syndrome Foundation, which is increasingly adding a whole variety of cool tools. Some individual medical articles are available, folks, at no charge. If a research was sponsored by the NIH, the authors can post it. They're obliged to post it. It may not be the super final version. It's called an author's copy, but you can get it. And as you know, some of the other search engines will find it for you. And I love the fact that you share your stories. You teach me. When I can look at a video, when I can watch how you hang out with your kids, boy, that tells me a lot. And I congratulate you. It's not easy to put yourself out there. I think about it every time when I put my photo on my website. But I love your stories, and I can tell you I read everything. We have a bunch on our MGH website. Pictures are worth 1,000 words, aren't they, folks? So, making choices, I'm not trying to say you have to do everything this way. Of course not. You have to weigh the same issues, the risk and the benefits. You've got the problems. You've got medications being offered. You've got your lifestyle. What means the most for your family? You can make choices. Testing, personal beliefs, of course, as a physician, I'm giving you our what we recommend, but you might make personal choices. I hope they're the safe ones. You want to learn the science, you're learning the medical knowledge, take the short term and the long term view too. So, a lot of stuff going on. So, I'm going to summarize now. I think my time is good. We'll have 10 minutes for questions. Creating a Myhre syndrome health plan is a terrific goal. Takes effort, flexibility, it's worth the time. But there's different strokes for different folks. One size does not fit all. Listen to my suggestions, find out what works for you, pay it forward. And I think you guys do this all the time. You share your know how with others. The know how that I hope you'll come to us will be the medical stuff. I know there's lots of discussions about certain medical issues, and ideally should be answered by a physician, but sort of sharing it helps too. And then I always mention research. Doctors have to be very careful about what's called coercion, but I frame it this way. When you come to me with questions, our team around the world is certainly trying to come up with answers for you, but we need your experience. So we're asking you to be part of the answer. It might be something as simple as, what do people with Myhre syndrome look like? Are there more males? Is it variant specific? Does anything predict the future? And yet another rainbow in my life and a field of gold, which is this Myhre syndrome conference. So I can't thank enough people, but I'm going to try. First of all, thank you for these great masks, which I have enjoyed, and now I'm finding different uses for them now. Thank you to you families, your networks who made this event possible, who did a lot of fundraising, and I know that is important and I appreciate that. We have this great professional advisory board, just the best people that I've ever worked with. I have a great Myhre syndrome clinic team, wonderful people. I thank the people in fund development at MGH who helped me raise funds, and the referring physicians, and also the geneticists within my own group. I have to thank Mark Lindsay, who's my co-director, This picture was taken when we were vaccinated, so we're safe there. And I'm going to throw out a special thanks to my wonderful husband. He has supported me and endorsed me through a lot of hours, a lot of late nights, and he's been great for this. And so to everybody, thank you, merci, gracias, grazie in every language. I don't know